This is the complete lecture on Chapter 22, the immune system. We'll start with the major points, and this entire lecture is coming from the review sheet, which is tied to the flashcards in Study Blue. If you use your review sheet while you're listening to the lecture, then that should familiarize you well enough with the material that you can then go to Study Blue and review the flashcards. The major points are the items that are the most important things for you to remember and keep straight. So be sure you review them first and foremost, and you can expect to see all of the major points on your test. I've divided the major points in this presentation into categories, and those categories match the specific points categories in the second part of the review. So our first part is the introduction. It's important for you to know that the lymphatic system and the immune system work together, but they're considered separate systems. In working together, they protect the body from infection and disease. Immunity is divided into two kinds, innate immunity and adaptive immunity. Innate means from birth, and the innate immunity is turned on from the moment it develops. Adaptive immunity means that it changes with the situation. So adaptive immunity is not turned on until you're actually exposed to the pathogens, the antigens, that it reacts to. Here are the major points for the lymphatic system. The lymphatic system consists of the fluid called lymph and the vessels that carry that fluid, the lymphatic vessels, and the organs that are full of lymphocytes. The lymphatic system returns the fluid, which mostly is formed by leaking out of blood capillaries. This excess fluid is returned to the blood, and in the process it is filtered for the presence of abnormal cells or infectious organisms or activated white blood cells. The lymphoid tissues and organs are those tissues and organs that have concentrations of lymphocytes. The lymphoid tissues and organs, by producing and storing lymphocytes, help with the adaptive immunological responses. Innate immunity is turned on from birth, but it also is pre-programmed. So the innate defenses are always the same. It does not matter what the threat to the body is, the innate defenses always react the same way. Innate defenses include physical barriers, which keep things out, phagocytes, which are cells that can eat things, immunological surveillance, interferons, complement, inflammation, and fever. There are two ways of looking at adaptive immunity: what kind of cell is responding, and what does that response entail. So there are two kinds based on the type of response: cell-mediated immunity and antibody-mediated immunity. But you can also classify adaptive immunity as active or passive and natural or artificial. There are four characteristics of adaptive immunity that we'll be exploring: memory, specificity, versatility, and tolerance. Adaptive immunity works in a particular way. These mechanisms are important for you to learn. We start with the presentation of some antigen. That antigen is foreign or perceived as being dangerous, and it activates an adaptive immune response. There are three kinds of cells that are going to be involved in adaptive immunity. The helper T cells, helper T lymphocytes, control the immune response by stimulating the other cells. The cytotoxic T cells are the ones that are responsible for cell-mediated immunity. They kill the abnormal or infected cells that display their particular antigen. The third kind is the B cells, and these are the ones responsible for producing antibodies. Let's talk for a minute about antibodies. There are 5 classes of antibodies. This allows them to perform specific functions. You'll be looking at those. And there are about 5 things that antibodies can do. When they bind to their antigen, they can neutralize, precipitate, agglutinate, activate complement, and attract phagocytes, all of which can result in inflammation. But please notice antibodies do not directly kill cells. Our last category of discussion for this chapter is disorders and regulation. We'll be looking at two classes of disorders, those in which the immune response is not enough and those in which the immune response is too much. And briefly we'll look at the nervous system and the endocrine system interactions with the immune system, which are still subject to a lot of research. Okay, moving into the details. We'll start with the lymphatics. Lymphatic circulation, remember, is the flow of the fluid called lymph through the vessels called lymphatic vessels. The smallest lymphatic vessels are the lymphatic capillaries. Please be sure to look at the picture in your book and notice that lymphatic capillaries, unlike blood capillaries, are blind-ended. That is, they dead end in the tissue spaces because they don't have the equivalent of an arteriole supplying them. Fluid flows into the lymphatic capillaries from excess tissue fluid. The capillaries themselves are made of endothelial cells, just like blood capillaries, but the cells overlap in a way that makes them easy to push out of the way when stuff's going into the capillary, but kind of shuts off if stuff were trying to get out of the capillary. Additionally, if you have inflammation in the tissues and swelling and edema, lymph capillaries stay open. Lymphatic tissues and organs are named that because of the concentration of lymphocytes in those tissues and organs. Lymphocytes got their name from the fact that they were found in lymph nodes, and lymph nodes are called lymph nodes because they filter lymph. And lymph means clear fluid. So the lymph got its name first. The vessels that carry the lymph are the lymphatic vessels. The lymph nodes are named because they filter the lymph, and the cells of the lymph node were named lymphocytes. So lymphocytes are called that because that's where they were first found and identified, not because that's really where their function is. Let's learn the very small difference between a lymphatic tissue and a lymphatic organ. The organs are more discrete. They are separated from the surrounding tissue with a fibrous capsule around them. And in general, the lymphatic organs may have other tissue in them, but the lymphatic part is still going to be like all the other lymphatic tissues. It's got a germinal center where new lymphocytes are being formed by mitosis. And there's just in that germinal center will be surrounded by maturing lymphocytes. So if you see a little cluster of lymphocytes with a dense center to it, the germinal center, that's a lymphatic tissue. And they can be scattered or they can be collected together. And if they're collected together with a capsule around them, they're called an organ. The lymphatic tissues are very often found scattered in the mucosa of the respiratory and digestive tracts. This is called the mucosa-associated lymphoid tissue, or MALT. And if you were looking at a section through the esophagus or the trachea or the small intestine under the microscope, you would see these little clusters of lymphocytes with that germinal center. And that's the lymphatic tissue of the mucosa. When you get into the appendix, it's just packed with it. So the appendix is considered particularly an organ of the immune system. And the lymphatic tissues of the small intestine, particularly the ileum, which is the last part of the small intestine, are really packed and very noticeable. And those are called Peyer's patches. And we believe they're there because you have bacteria that live in your large intestine. They're supposed to be there, but if they try to sneak backwards into the small intestine, the Peyer's patches are there, and the appendix is right there to help alert the immune system to the presence of bacteria that are not behaving the way they should and staying in the large intestine. Our lymph organs include the spleen, the thymus, the tonsils, and the lymph node. The tonsils form a ring around the pharynx. So you have tonsils in the top of the throat, the sides of the throat, and the base of the throat, right at the base of the tongue. The tonsils, if you look at the surface of them, have deep, deep folds in them called crypts. So food particles will get trapped in these crypts, and if there are any pathogens there, then That gives sort of an early warning to the immune system. The spleen is the largest of the lymph organs, and it's not entirely lymphatic in its function. If you look at the spleen under the microscope, you see large spongy areas called red pulp, which are full of red blood cells, which are being sort of stored there. They're still in the blood vessels, they're just sort of sitting there milling around. And the white pulp, which surrounds the arteries of the spleen, and is just a package of lymphocytes, just packed of lymphocytes surrounding the arteries. The spleen's spongy red pulp is also full of macrophages, and these macrophages in the spleen can kind of crawl around. They're going to look at old red blood cells. You remember we already talked about how you recycle old red blood cells in the spleen. And spleen cells, spleen macrophages, also continuously remove platelets. That's just part of their job. The spleen is also a major hangout for the cells that produce antibodies. These are called the plasma cells, and also the memory cells of the immune system. The spleen's a nice, safe place for these cells to just sort of spend their life. Sometimes the spleen has to be removed if it's traumatized in, say, an automobile accident. Because it's such a spongy organ, it's hard to patch it up. So generally they'll do a splenectomy. They'll remove the spleen, and in some cases that means the individual is more susceptible to infection. You can imagine a lot of their memory cells are removed, but those are pretty well scattered throughout the body. And sometimes the spleen is removed because someone has a low platelet count, and since the spleen's job is to remove platelets, removing the spleen can get the platelet count to go back up. The thymus is in the chest. It's superficial to the heart. In babies, it's quite large and can extend up into the neck. As the baby grows larger, the thymus doesn't grow as fast. So as the body gets larger, the thymus is relatively smaller and smaller. And finally, at about puberty, it starts to actually literally shrink away. The thymus's job is to train the T cells. They're called T cells because they're trained in the thymus. So maturation and development of T lymphocytes is the job of the thymus. We know that the thymus secretes hormones. One of them has apparently an immune function, and it's called thymosin. Another kind of lymph organ is a lymph node. You have lots of lymph nodes. They are scattered along the lymphatic vessels. They're the only organs that filter lymph. And as they're positioned along the lymphatic vessels, clusters of them are found in your armpits, in your groin, in your neck, and additionally in the intestine. So you have intestinal nodes, you have iliac nodes along the common iliac artery and vein, you have inguinal nodes in the groin, you have axillary nodes in the armpit, you have cervical nodes in the neck. So that lymph is filtered no matter where it comes from. It's filtered before it drains into the deep lymphatic vessels in the torso. Remember that the cells in lymph nodes are called lymphocytes because they were found in lymph nodes. The lymphocytes in lymph nodes are of all types, including B lymphocytes, the ones that make antibodies, and the different kinds of T lymphocytes. There are other cells in the lymph nodes, most notably cells which we'll call antigen-presenting cells. We'll talk about those in a minute. And because anything that gets into the interstitial tissue can get into lymphatics and then filter out at a lymph node, any cancer cells that metastasized in a tissue may wind up moving into a lymph node. So that's a common secondary site for cancer to establish. Lymph nodes have two sets of vessels. The afferent vessels bring lymph in, and the efferent vessels carry lymph back out. So the flow of lymph starts at the lymph capillaries out in the body tissues. And by the way, there are no lymph capillaries in the nerve tissue of the brain or spinal cord. Remember, they have a blood-brain barrier, so there's no extra fluid in the brain. All lymph below the diaphragm drains into a tiny little sac called the cisterna chyli. The cisterna chyli is actually the end of the thoracic duct. So right below the diaphragm sits the cisterna chyli. It passes through the diaphragm as the beginning of the thoracic duct. The thoracic duct is going to go along the thoracic aorta, and it's reaching its destination at the left subclavian vein. Right before it connects to the left subclavian vein, another duct drains into it. This is the left lymphatic duct, and the left lymphatic duct carries all the lymph from the left arm, the left thorax, the left side of the head and neck. All of that drains into the left lymphatic duct, which dumps into the thoracic duct, which then empties into the left subclavian vein. On the right side of the body above the diaphragm, that's the right arm, the right side of the chest, the right side of the head and neck, drains into a right lymphatic duct, and that dumps directly into the right subclavian vein. Okay, so that's our review of lymphatics. Let's move on and talk about immunity. Remember, there are two kinds, innate and adaptive. Remember that innate means from birth. Innate immunity is turned on. You don't have to wait to turn it on. It's automatically activated. It includes different mechanisms that will respond no matter what the danger is. And it has programmed responses. And it also has some elements that really aren't active. They're passive ways of keeping pathogens out of the body. But if pathogens do get in, then we have active ways to inhibit or kill those pathogens. And all of that's part of innate immunity. So the passive part involves the physical barriers. They just keep things out. You have a stratified squamous epithelium, which in your skin is keratinized. It helps keep fluid out. The moist, non-keratinized stratified squamous epithelium lines the mucous membranes where they come in close contact with the external environment. So your mouth is stratified squamous epithelial lining, your pharynx, your esophagus, the vestibule of your nose, the anal canal, the vaginal canal, all of these are stratified squamous epithelium. Additionally, secretion of mucus physically impedes the invasion by pathogens. Please note, mucus doesn't kill anything, it just traps it, and then the cilia of your respiratory tract are supposed to move that mucus up and out. And finally, excreted fluids that wash the body surface help to prevent pathogens from attaching, and that includes tears, saliva, and urine. So if a patient has a UTI, a urinary tract infection, we encourage them to drink a lot of fluids, and that just kind of keeps the bacteria in the bladder from getting too concentrated. You're just constantly washing them out and diluting them out. There are also chemicals that are excreted onto the barrier itself. They'll inhibit or kill pathogens as they land on the body. Stomach juice, anything you swallow is not in the body until it gets absorbed. So you can have pathogens in your stomach. You're going to kill them with stomach acid. Perspiration is acidic, and acid inhibits bacterial growth and fungal growth. And then there's a nice little enzyme called lysozyme that actually lyses cell walls of bacteria and causes the cells to burst, and it's found in tears and saliva. Remember, these are the group of chemicals that are actually on the surface, so they're helping to keep things out of the body. If something gets in past our barriers, then we have chemical and cell responses to keep it from getting the upper hand until our adaptive immunity can take over. So as soon as there's trauma of any kind, damage of any kind, the innate immunity mechanisms are going to come into play. So the first thing that happens is a cell gets hurt, whether it's from physical trauma or if it's because of an infection. If you have a viral infection and the first cells infected by the virus die, when they die, they're going to trigger innate immunity. The chemicals of the immune system are called cytokines, and some of these cytokines are hormones, like thymosin, and others are called local hormones or paracrine secretions, like the group called the interleukins. Anything that works at a local level is called a local hormone or paracrine secretion. So if a cell is secreting a cytokine, a chemical that affects a cell that's sitting right next to it, that's a paracrine secretion. Chemical responses include interferons. Interferons are secreted by cells that have been infected by a virus, and as they go to neighboring cells, they tell those cells to stop making DNA because that's the way viruses spread. And interferons also activate NK cells. NK cells are natural killer cells. They're actually lymphocytes of innate immunity, and they can attack and kill other cells, including cancer cells. TNF stands for tumor necrosis factor. It helps to kill tumors, and that means it's a cancer fighter. And then there's a whole category of interleukins, which we're not going to get bogged down in. Another mechanism of innate immunity is inflammation. Now, inflammation is another one of those things that if you get too much of it, it can kill you, and if you don't have enough, you can die from infection. So we want inflammation to be just right. It's triggered by trauma. Damaged cells release chemicals. These are some of these cytokines, which are called inflammatory mediators. That is, they trigger inflammation. There are 4 classic signs of inflammation: redness, heat, pain, and swelling. Redness and heat are due to local vasodilation, and we'll look at the cells that secrete the vasodilating factors. Vasodilation brings in more blood, makes the tissue warmer, and the warm tissue inhibits bacterial growth. At the same time, it jacks up your own cell's metabolism, so that helps fight infection. And also, when you have more blood coming in, have more white blood cells coming in to fight the infection. The trigger for swelling is histamine, and histamine makes the capillaries leaky, and that means the plasma proteins, which normally stay in the blood, will leak out, and they'll have an osmotic effect, and that's what creates edema, the swelling. If you have a little localized edema, it's probably going to be painful. You'll probably be nice to it. If you have swelling in a joint, it can prevent movement, and all of that will allow some rest, so that the damaged tissue can heal. But additionally, when the tissues swell, the veins coming out of that tissue get collapsed, and that pushes all the fluid into the lymphatics, which means any pathogens that are in that area will get sent through to a lymph node where they'll get filtered. The pain of inflammation is triggered by specific chemicals that are secreted. We have identified some chemicals that when you put them on pain nerve endings, it elicits a pain response. There are specific ion channels that respond to just these pain-inducing chemicals, and they're actually doing research on how to block them so we can stop pain signals from coming through. Pain helps reinforce the need to rest. If you broke a bone and it hurts to lean on it, then you'll rest it and let it heal. And it also allows for learning. If you do something and it hurts, you don't do that again. Okay, our next mechanism is fever. And fever isn't an accidental thing. Fever is a deliberate change to the thermoregulatory center of the hypothalamus. And fever can be triggered by certain chemicals, including some chemicals that are released as bacteria die from being attacked by your white blood cells. These can circulate in the blood. They can get to the hypothalamus of the brain and induce fever. So the term for that is pyrogen. P-Y-R means fire. So pyrogen is something that increases body temperature. Our next innate immunity mechanism is complement. And complement is a series of plasma proteins. They're circulating in your bloodstream all the time. They're made by the liver cells, and they're secreted in an inactive form, and they're just always there. So they're there ready to go as soon as you activate them. Activation can be the classic pathway by antibodies, as we'll see when we get to antibody action, or the direct pathway that's activated by chemicals produced by bacteria. Just like these chemicals can trigger fever, they can also activate complement. Complement binds to the surface of bacteria, and that marks the bacteria and triggers some responses, including inflammation. Macrophages are pulled in. The macrophages find it's easier to eat the bacteria if they've been activated by complement, and the complement itself directly punches holes in the bacterial cell membrane, and once they have holes in them, their cytoplasm comes out and they die. So complement actually directly kills bacteria. The complement process is a cascade, and cascades, we looked at a cascade in the blood clot formation was a cascade. A cascade is always a series of enzymatic reactions that each step magnifies the next step. So there are about 3 different steps in the complement cascade. You can start with a little bit of complement activation and wind up with a huge amount of activated complement, and then lots of holes punched in lots of bacteria. And then that complement coating on the bacteria makes it easier for the macrophages to come in and catch the bacteria and eat them. And this term opsonization, it's kind of a cute term. To opsonize something means to make it taste good. Okay, so that was the chemical responses. Now we're going to look at the cellular responses. Remember, we're still looking at innate immunity. Our cellular responses include the activity of neutrophils, eosinophils, basophils, which are the three kinds of granulocytes you learned in the blood, plus some tissue cells, mast cells, and macrophages. And macrophages are actually the end stage of development of the monocytes. And a kind of cell we haven't talked about, at least in AMP2, and that's the dendritic cells. Dendritic cells, like mast cells, are found out in the tissues. If you have trauma or infection and you get that inflammatory response and you get this rush of blood into the area that was inflamed, the first cells to respond in large numbers are the neutrophils. And you'll remember neutrophils are the most abundant of the white blood cells in the bloodstream, so it makes sense that they'd be the first ones to get there. Neutrophils give us what we call a respiratory burst. They start secreting chemicals which generate oxygen. Oxygen is very toxic to cells. It kills everything. So neutrophils don't try to identify who are the good guys and who are the bad guys. They kill everybody, including themselves. So their lifespan's pretty short. Once a neutrophil arrives at a site of trauma, it's got a lifespan of maybe just a few hours. And while it's there, it can also do some phagocytosis, not as much as the monocytes and macrophages, so we call these microphages. Another cool thing neutrophils do is they actually get out through the intestinal lining. They are little suicidal cells at this point. If they go out in the intestinal lining, they're going to get digested. So they make it through the intestinal lining so that any bacteria that survived the hostile environment of your stomach acid and made it all the way to your intestine, like the bacteria that cause food poisoning, salmonella is one, can be killed by the neutrophils. Our second kind of cell is the eosinophils. Eosinophils, like neutrophils, are little microphages. They can eat some. I've seen pictures of them lined up along an infected, a worm infection that was embedded in an intestinal wall, a hookworm, and they were just sitting there chomping away at this worm. Eosinophils seem to specialize in fighting parasites such as worm infections, but they also secrete antihistamine, so part of their job apparently is to turn down the immune response. And interestingly, eosinophils are also going to be high in number with allergies. So when you're having an allergy attack, particularly people with asthma or other chronic allergies, the eosinophil count can get really high. Normal eosinophil count is only 2%, and it may be as high as 20% in a raging allergy. Basophils are very rare in the blood, but they have a lot in common with mast cells, which are found in loose connective tissue. We're not really sure where mast cells come from. We used to think that they were basophils that had gotten out in the tissues, but studies have shown that they are not the same cells. So mast cells are somehow being formed in the marrow and just getting out to the tissue somehow undetected in the blood. Both of these secrete histamine and heparin. Histamine is the chemical that makes capillaries leaky, so it triggers edema. It's also a vasodilator, so it brings the blood in. Heparin is an anticoagulant. Next up, the macrophages. Macrophages are fewer in number in the circulating blood, so they're going to wind up getting to a site of trauma or infection a little bit later than the neutrophils, which means the neutrophils have already done all the killing and dying. So macrophages come in, they catch things, they eat things, they kill the pathogens that are left, they clean up everything, including any dirt or wood from splinters or dead neutrophils or whatever. Macrophages are the cleanup crew. Some macrophages wander. They can roam through loose connective tissues. Others kind of lodge in an organ and stay there. So you have microglia in the brain. Now, microglia can wander through the brain, they just don't leave the brain. Kupffer cells are the liver macrophages, and they stay kind of parked in the walls of the capillaries of the liver. Spleen macrophages can wander through the spleen. Alveolar macrophages can wander through the alveoli of the lungs. There's an old-fashioned term you may see sometime called reticuloendothelial cells. This was a term coined by some early histologists. They kept seeing macrophages everywhere in all different organs, and that's just the name they gave them. Macrophages and dendritic cells are very important because they are antigen-presenting cells. They're the connection between the innate immune reaction and the adaptive immune reaction. Basically, they go into the tissues, or in the case of dendritic cells, they're sitting in the tissues. They phagocytose whatever is in their vicinity. They process and present what they have eaten. So let's see how that's going to happen when we get into adaptive immunity. The next kind of cell is the NK cell. NK stands for natural killer, and these are actually lymphocytes, but they're kind of always on the lookout for some particular abnormal cell markers. So they're not adaptive, they're already pre-programmed to respond to a particular surface chemical, and they're already turned on, which is why they're part of the innate immunity. But they're programmed to look for particular abnormalities on the surface of cells that you might see in different kinds of cancer cells or different kinds of infected cells. So once the NK cells see those, they catch them and they destroy them. And they're going to catch a lot of pre-cancers before they have a chance to establish into full-blown cancer. Okay, moving on to adaptive immunity. The lymphocytes are responsible for adaptive immunity because they have the ability to recognize and respond to antigens. You have a difference between active and passive immunity, and you have a difference between natural and artificial immunity. Immunity is active if you're exposed to antigen and you produce your own immune response. Immunity is passive if someone else generated the immune elements, the antibodies or the activated lymphocytes, and you just got those immune elements from them. So if you get an injection of antibodies from someone, that's passive. Now, you can do that naturally, but it's always mother to child. Mothers provide antibodies across the placenta to the fetus before birth and through the milk when nursing. So that's passive. The mother's giving antibodies to the baby, but it's also natural. It can be done artificially through vaccinations or through gamma globulin injections. And that's medical intervention. So if you're thinking artificial, it's always somebody's given you either a shot or a vaccine orally, almost always a vaccine shot. And remember, if it's a vaccine, you make your own immune response. So it's artificial, but it's active. If you're given gamma globulin, that's somebody else made those antibodies. You didn't make your own, so it's passive. So active natural means you got sick, you got infected, and your immune system took care of it. That's the natural way to develop immunity. Okay, so we know the lymphocytes are the cells of adaptive immunity, but we do have three kinds, the T cells, the B cells, and the NK. And we already know the NK are really actually part of innate immunity. So we're going to focus on the T cells and the B cells. T cells are called that because they mature in the thymus, and B cells mature in the bone marrow along with the NK cells. So again, those NK cells, we're done talking about them. T and B cells are pre-programmed for their specific antigens, but they're not activated, so they're part of your adaptive immunity. You've got just a huge number of T and B cells that are pre-programmed, but unless you're exposed to that antigen, they won't ever get activated. Okay, so we need to talk a little bit about antigens. Antigen means you generate an antibody. That's where the term comes from. Antigen is any chemical that could trigger an immune response. Now, you have antigens in your body that belong to you. They're your self-antigens. But if you were to give a donated organ in a transplant to someone else, then those antigens that belong to you are foreign to the person you donated the organ to. And that includes transfusion reactions. There are also other kinds of foreign antigens besides just the antigens that are self to another human. Abnormal chemicals can be antigenic. You can be allergic to chemicals. Chemicals can be toxic or not. They could just be allergy-inducing and not harmful at all. And then if it's an infectious organism, then it's called a pathogen. So the first step in adaptive immunity is for some component of the immune system to make a connection to an antigen. That is, somebody in the immune system had to recognize that antigen. The antigen can be loose in the body, that is sort of just wandering around in the tissue fluids, such as virus particles, or it could already be processed by a macrophage or a dendritic cell, or it could actually be infecting a cell. So these antigen-presenting cells are really important. The macrophages and dendritic cells will eat the antigen, process the antigen, and then display the antigen. And that antigen display is through a special protein on the surface of the antigen-presenting cell, and it's called MHC2. And MHC stands for Major Histocompatibility Complex, and it's just a term we use when we're matching tissues for donations. So remember, MHC2 on your antigen-presenting cells displays something that was eaten by the cell. Here's what I ate. The cytotoxic T cells provide your cell-mediated immunity. The cell itself is going to go out and actively fight an infection. Once it's activated, that is, it's met the antigen that it responds to, it's going to go look for that antigen anywhere it can find it on the surface of foreign cells, and that includes transplants or virus-infected cells or cancer cells. An activated cytotoxic T cell goes to look for its own antigen on the surface of a cell. And when it finds that cell, it injects the cell with chemicals that kills the cell. It kills the cell in a very particular way. It shreds the DNA, it poisons the mitochondria, and it causes the cell to break apart into little separate bubbles of dead cell. This process is called apoptosis, which means cell falling apart. And it doesn't trigger inflammation or necrosis. So T cells, cytotoxic T cells, recognize their antigen when it's displayed, and the way that the cell, the infected cell, is displaying it is on an MHC1, not an MHC2. MHC1 displays antigen that is being produced by the cell. So MHC1 says, here is what I am making. A second kind of T cell is called a helper T cell. And the helper Ts do exactly that. They stimulate both T and B lymphocytes. This is called a co-stimulation, and that helps to make sure that the cells only react when there really is a problem. So that if a B cell happened to find something that it was responsive to, but that something wasn't dangerous, then without a helper T to stimulate it, it would simply not generate an immune response. So the helper Ts have to be activated by the antigen-presenting cells, and that helps to just sort of double check and make sure there really was some damage incurred before the immune system gets activated. Once it's activated, the helper T stimulates other lymphocytes, triggering division of T and B cells. That's actually a cloning process. They help stimulate antibody formation and stimulate the formation of memory cells. So they really are just sort of the central key cell of your immune system. Without helper T cells, you really don't have much immunity at all. There's a last kind of T cell. It's called a suppressor cell. These are fewer in number and are activated late in an immune response. Apparently their job is to kind of turn things down once the infection is over. The other main kind of lymphocyte is the B lymphocyte. These are the ones that are responsible for antibodies. We call that humoral immunity. The term humoral just indicates some chemical being carried in a body fluid, and in this case, of course, that's antibodies in the blood. B cells can be activated by direct contact with loose antigen. So if you had a site of inflammation that was due to a viral infection, the B cells would come into that area. If they recognize that virus, they would be activated right there on the spot. And as long as there were helper T cells there to co-stimulate them, they would become activated and start making antibodies. So once it's activated, a B lymphocyte clones itself. So do the T cells as well. And the descendants of the B cells are called plasma cells. They're going to go off to different tissues, including the spleen, sit somewhere warm and safe, and produce the circulating antibodies, and let the antibodies go fight the infection. Okay, so let's talk about antibodies. Antibodies are also called immunoglobulins or gamma globulins. Globulin is a category of plasma proteins in the blood. The antibody molecule, you should look at a picture of it in your book. There's a long end, sort of a stem with two prongs on it. The stem end is the large end, the constant region. There are actually 5 different constant regions, giving you the 5 classes of antibodies. But the 2 prongs on it are the variable end. And those 2 variable ends are, first of all, they're identical to each other, but second of all, they're a match to some specific antigen. So each different antibody reacts to one specific antigen. And when you think about all the different kinds of antigens there are in the world, plus the fact that with mutations there are new antigens being formed all the time, every time a virus mutates, then you would need to be able to produce new antibodies to match it. So that is the basis of specificity. It's also the basis of versatility, as we'll see. So let's talk about our 5 classes of antibodies. Here's the names of them. In an IgA molecule, you actually take 2 antibody molecules and stick them together with a little extra protein that makes them very sturdy and resistant to digestion. And these are secreted in body fluids. And your book doesn't mention it, but I know that when a nursing mother is supplying antibodies to her baby while she's nursing, it's through the milk, IgA antibodies. So what these antibodies do is they will bind to any antigens that are just on the surface. So if they land on the surface of your eye or in your mouth or in your infant, then those potentially pathogenic organisms can be removed before they even get in. IgD is a very special kind of antibody. It's stuck to the surface of the B lymphocytes, and that's how those cells know which antigen that they're specific to. IgE is found on the surface of mast cells. IgE is associated with inflammation caused by mast cells, and it is the basis of allergies. So if you're allergic to goldenrod pollen, when you inhale that pollen, it binds to the IgE antibodies on the surface of the mast cells, and that triggers inflammation. IgG is probably the most important one. This is the one that we call gamma globulin. When we're giving someone gamma globulin injections, this is the one. It's the most abundant circulating the antibody. It works mostly by activating complement. If there's a virus, it can actually stick to the virus and prevent the virus from infecting cells. That neutralizes the virus. If a bacteria is secreting a toxin and you have an antibody to the toxin, it can actually stick to the toxin molecules and make them stay where they are. That's called precipitation. And IgG is the one that crosses the placenta to protect the fetus. And that protection can last for months after the baby is born. IgM is probably my favorite. It's a pentamer. That means you take 5 of these antibody molecules and you stick them on this big protein so that the antibody's business end is sticking out. They're so big that they can actually attach cells to each other, and that's what agglutination is. So this is the basis of transfusion reactions and the agglutination associated with getting a transfusion of the wrong kind of blood. So in IgM, the other interesting thing about IgM is that it's the first antibody to be secreted, and it's only secreted early in an infection. So you could actually take a blood sample from someone, test for IgM, and you know whether it's been a chronic infection or an acute infection, because if it's chronic, there won't be that much IgM anymore. Okay, so here's what antibodies do. They neutralize, precipitate, agglutinate, activate complement, and attract phagocytes. Neutralizing means the virus is covered in a way that prevents it from entering a cell. Precipitating means you stick small molecules together into a big mass, and that keeps them from diffusing away. Agglutination, sticking the cells together. Activating complement, when the antibody sticks typically to a bacterial cell, complement is activated. Remember what complement does. It triggers inflammation. It coats the cell and makes it easier for macrophages to eat it. That's opsonization. And complement itself actually plugs holes into the surface of the bacteria and directly kills the cell. So it's not the antibody killing the cell, it's the complement killing the cell. So antibodies themselves, when they coat bacteria, can make it easier for macrophages to attach. Okay, an important characteristic of adaptive immunity is memory. In fact, this is what the word immunity means. It means you're safe. So you're not safe the first time you met an infectious organism, you got sick. But assuming you survived that first exposure, now you have protection. So memory is the key feature of immunity. And it's the one that we mimic when we do vaccinations. All a vaccination is a way to get that first exposure without getting sick to generate the formation of the memory cells. So with both T and B cells, once they're activated, they clone themselves. And as clones, what that means is they all respond still to the same antigen, and some of those cells will just go hide in a lymphatic tissue or organ and wait until you're re-exposed to that same antigen again. And once they're activated again, the activation the second time is faster and stronger, and you can actually vanquish the pathogen before you have any symptoms of illness. These memory cells can live for decades, demonstrations of at least 70 years, and they're regenerated every time you're re-exposed. So if you are 80 years old and you were exposed to chicken pox every year until 1990, then your memory cells have lived for probably 60 years. Okay, let's go back and talk a little bit more about the cloning. When these cells clone, the gene that makes the variable region on the antibody, or the variable part of the T cell receptor, can actually tweak itself a little bit and give you a slightly different version of that antigen recognition process. So close but not identical. And as you keep making different clones, you get slightly different versions of these. The ones with the best fit are the ones that are the most active. So the ones that don't fit very well tend to just die out and go away. So as the best fit persists, this is the whole idea of why we call it adaptive immunity. It gets better over time. Okay, our fourth characteristic of immunity was tolerance, and we need to talk about tolerance in terms of what happens if you don't have it. Tolerance is the ability of the immune system to ignore your own self-antigens. So it's only a problem if you don't ignore self-antigens, and that's an autoimmune disease. So if your immune system inadvertently attacks self-antigen, you start attacking your own tissues. Well, you always have those tissues. They're present all the time. You can't vanquish them the way you can an infectious organism. So it's a chronic, continuing condition, and the only way to treat it is by suppressing the immune system. Tolerance develops as the T and B cells mature in the thymus and bone marrow, and we don't understand completely how it works. And we also know that because you generate new lymphocytes throughout your life, you can continue throughout life to develop cells that, for the wrong reason, attack self-antigen. And we identify three different ways that self-antigen for some reason becomes attacked. The first is if some other chemical that you took in by mouth or whatever stuck to a normal cell and made the immune system think that that was a foreign antigen. For example, when people are allergic to penicillin, the penicillin molecule itself is not big enough to generate an immune response, but if it sticks to something else and gets bigger, then all of a sudden you have an allergic reaction to something as if it were foreign. But if then that allergic reaction attacks the cells and continues to attack the cells, now you have an autoimmune disease. There are few body tissues that don't directly get a blood supply, but if they are ever injured in any way and the cells that were hidden from the immune system are now exposed to it, you can actually start making antibodies to them. Some notable examples of that, thyroiditis, the thyroid follicles are usually hidden away from the immune system. So if you have any damage to the thyroid gland, then you start making antibodies to thyroglobulin, and so you have an immune hypothyroidism. Another example, the sperm antigens are usually hidden from the immune system, but if a male who after puberty develops mumps of the testes, then inflammation of the testes can allow the blood to get in there and start making antibodies to sperm cells. So that's our second case. Our third case is if you have some foreign antigen that you really are supposed to be attacking, but it has properties so similar to your own antigens that the antibodies that are attacking the foreign antigen also attack your own antigens. That's a cross reaction. And that's what we see in some cases of strep infections like strep throat that then lead to autoimmune diseases like rheumatic fever. Okay, another example of too much of an immune response is an allergy. Allergies are classified as hypersensitivities. You're too sensitive to something you shouldn't be sensitive to at all in the case of an allergy. The antigen is called an allergen, and allergens are non-pathogenic. The allergen itself cannot cause a disease. It's not a disease-causing organism, but your immune system attacks it as if it were a disease-causing organism. And remember, it's the IgE antibodies on the mast cells that trigger the inflammation associated with a typical allergy attack. So if you have swelling in the nasal mucosa, or if you have a skin allergy and you break out in a rash, all of that's due to the IgE mast cell interaction. There are other kinds of hypersensitivities. In some cases, there's so much antigen that when the antibody binds to it, just the antigen-antibody complex can cause an overreaction of the immune system. And in some cases, those antigen-antibody complexes, it's called immune complex, can get stuck somewhere like in your kidneys and cause chronic inflammation. So that would be a hypersensitivity involving your kidneys and can actually damage the kidney so severely that you need a kidney transplant. Obviously, anaphylaxis is a severe overreaction of the immune system. In anaphylaxis, you have so much inflammation that your blood volume drops so low that you don't have enough circulating blood. The last kind of hypersensitivity is called a delayed hypersensitivity, and this is the only one that's due to a T cell reaction, not to antibodies. An example of this is contact dermatitis, the itchy inflammation associated with poison ivy and other poisonous plants. And it usually develops more than 24 hours later rather than the immediate hypersensitivities associated with antibodies. Okay, so autoimmune diseases and hypersensitivities are overreactions of the immune system. Immunodeficiency diseases occur when there's not enough of a reaction, and what you're going to die of then, obviously, is the infectious organism can get in and your immune system's not enough to fight it off, or you have a cancer and you're not doing enough immunological surveillance. Either way, cancer or infection can cause you to die. And you can have an immunodeficiency disease that you're born with because of a genetic mutation, or you can have one as a result of infection. The primary innate immunodeficiency disease is SCID, severe combined immunodeficiency disease. And this is a genetic condition in which some critical part of the immune system is missing due to a mutated gene. There are different varieties of this depending on which gene it is. Children born with SCID and it's not diagnosed will die of overwhelming infection. If you know from genetic counseling that your baby's going to be born with SCID, they try to have it born in a sterile environment. They keep it in a sterile environment, which is very difficult to do with babies, but they can do it until they're old enough for genetic treatments. And we do have some based on genetic engineering now. They can take the white blood cells out of the child, genetically engineer the missing element into the white blood cells, reinfuse those white blood cells into the child, and some of those children are alive and reasonably normal now with no major health issues. AIDS, acquired immune deficiency syndrome, is the result of an infection. This is the HIV, human immunodeficiency virus, and it infects the helper T cells. And remember, those are the keystone cells of your immune system. So without helper Ts, you have no immunity at all. And we know mostly from HIV/AIDS research which cancers are protected against, and some of those cancers we know are virally triggered now. Okay, last little bit of information. We know the nervous system interacts with the immune system. We know that hormones interact with the immune system. You should read that section in your book. It's not on your test. It's interesting, though, to note that emotional distress can trigger immune suppression. So if you're stressed out, you tend to have a greater chance of getting ill. And we know, in particular, herpes infections, which once you're infected with herpes, you're stuck with it the rest of your life. The herpes virus lives in your nerve cells. When you have emotional distress, it can trigger a fever blister, a cold sore, or shingles, just from the emotional distress alone. Okay, well, that's it. I hope that helps. Be sure you review the review sheet. There is on the CD a component on the immune system that should help you. There is also, of course, a set of flashcards, and a practice quiz will be coming. See you for the respiratory system.